Okay, so this video is for the last part of chapter 21, beginning at slide 77. And we are still on the circulatory system, and we're talking about controlling the blood flow through the body. And so one of the concepts is vasomotion. So in all of our capillary beds, we have precapillary sphincters, and by opening and closing the different precapillary sphincters, we can alternate which areas of the capillary beds are going to be receiving blood every few seconds. That means that we don't have to have all the blood going through every capillary all the time. And we can also kind of put it where it's needed most. So to control cardiac output and blood pressure, there are different levels. There's autoregulation, neural mechanisms, and endocrine mechanisms. So autoregulation, of course, means it's self-regulating. That will cause immediate little local homeostatic adjustments like opening and closing precapillary sphincters. Neural mechanisms are going to be controlled by the nervous system, okay? And endocrine mechanisms, of course, are going to use hormones, and they're going to be for long-term changes, where we're going to use the nervous system for immediate and quick changes. So autoregulations would be things like, okay, the stimulus is chemical changes like decreased oxygen or low pH, increased physical tissue activity, or physical stress. And so autoregulation would be the precapillary sphincters would respond by decreasing local resistance and increasing in blood flow, and then hopefully in just around that area we would then resolve that problem. If it does not resolve with autoregulation, then we have to move to endocrine and neural functions, and sometimes they're all going at the same time. So endocrine mechanisms would be something like your kidneys would send an endocrine response. We would have a long-term increase in blood volume and blood pressure, okay, by increasing erythropoietin, by stimulating angiotensin II, and all of those things, aldosterone, would all be things that would increase blood pressure and blood volume. And then the nervous system, which is a faster fix, would have stimulation of receptors that are sensitive to changes in blood pressure, activation of the cardiovascular center in the medulla, and then that would allow us to have a short-term increase in blood pressure by sympathetic stimulation of the heart and by vasoconstriction. So this is a quick fix that's a little wider spread than the autoregulation. This would be a long-term fix. Okay, so again, autoregulation is controlling local resistance, but we don't really change cardiac output. So we do that by opening and closing precapillary sphincters and causing local vasoconstrictors to reduce blood flow. Vasodilators will open precapillary sphincters. Local vasodilator indicators are low oxygen or high CO2, a buildup of lactate or lactic acid, nitric oxide, high potassium, or high hydrogen ion concentrations, which would make the blood acidic, chemicals released by inflammation like histamine, and elevated local temperature. All right, neural mechanisms involve the cardiovascular center, which is in the medulla, and it has two centers, a cardioacceleratory center, which of course speeds up the cardiac output, and cardioinhibitory center reduces cardiac output, mainly by controlling heart rate. Okay, we also have the vasomotor center, which is going to control the diameter of blood vessels. This is 100% controlled by the sympathetic nervous system, and so it's only controlled by adrenergic nerves. Vasodilation is controlled by cholinergic nerves because this would be in response to needing to dilate high blood pressure, and that relaxes smooth muscle. Vasomotor tone is produced by constant action of sympathetic vasoconstrictor nerves. All right, we also have some reflexes involved in controlling heart rate. There's a baroreceptor reflex because we have baroreceptors, and if you ever watch the weather report, you hear about the barometric pressure. So anything with baro in the front of it is going to be looking at pressure differences. In this case, it's going to be blood pressure. And chemoreceptors are looking at concentrations of things like oxygen and CO2 and other ions. So the baroreceptor reflexes are located primarily in these two areas. They are stretch receptors, so they're looking at the amount of stretch based on blood pressure, and they're in your carotid sinuses, that's where your carotid arteries, okay, and the aortic sinuses. So the aortic sinuses, we learned, are just outside of the aortic semilunar valve, and the carotid sinuses would be within the carotid arteries. So if you have any change in the blood pressure in the ascending aorta on its way to the brain, it will trigger the aortic reflex, which will cause an adjustment in blood pressure and flow in the systemic circuit. Now, you may have felt this reflex before. If you were ever lying down and then sat up very quickly, what happens is gravity kind of pulls the blood down away from your head. And so your carotid and aortic sinuses, baroreceptors register this as a quick drop in blood pressure. It may have made you feel dizzy or faint, and you had to wait for your blood pressure to even out, or you had to lay back down, and that's to ensure that your brain is getting enough oxygen at all times. When your blood pressure rises, the cardiovascular centers will decrease cardiac output and cause vasodilation of the peripheral vessels. That's to help allow for less resistance to lower blood pressure. If your blood pressure falls, the cardiovascular center increases cardiac output and causes vasoconstriction to raise the pressure. Atrial baroreceptors will monitor the blood pressure at the end of the systemic circuit. Atrial as in the atrium, the right atrium. And that's where we had the Bainbridge reflex. We've already talked about that. If we have too much venous blood returning into the right atrium and stretching the walls, then it will cause the heart rate to increase so that we're emptying that atrium more frequently. All right, so here are some graphics that just basically go over those same things. Since most of you are planning on going into the medical field, this is probably one of the more critical areas of understanding how the circulatory system responds to different stimuli, whether it's a drop in blood pressure or too much blood pressure. Chemoreceptors are also looking for concentrations of different chemicals like oxygen and CO2. It's monitoring blood pH. And just like we had our baroreceptors in the aortic sinuses and carotid sinuses, guess what? We have chemoreceptors in carotid bodies and aortic bodies. And so what are they looking at? They're looking at the concentration of these ions in cerebrospinal fluid. They're looking at breathing. We're going to get into the respiratory system in the next unit. And they're controlling the blood flow to the brain. So the brain needs constant oxygen and constant glucose. And so these chemoreceptors are going to be looking at those factors and adjusting blood flow and breathing rates accordingly. Okay, so some more graphics here. All right, cardiovascular center and central nervous system activities. Did you know that you can affect your heart rate by your thoughts? Okay, so here, let me show you a little example. What if I said, okay, I've decided to make your test for this unit worth 90% of your final grade. Now, chances are your heart rate just went up a little bit. Now, that's not true. I'm not really going to do that. But you're thinking about something that hasn't even happened yet has caused your heart rate to increase. But this also works the other way. If you've ever gone in to take your blood pressure, you can cause your body to relax. And by slow breathing and relaxing thoughts, you can actually lower your blood pressure. Okay? So your thought processes and your emotional states can elevate your blood pressure by cardiac stimulation and vasoconstriction. And you can also do the opposite. You can relax and cause vasodilation and lower your blood pressure. For the endocrine system, hormones have both short-term and long-term effects. For example, epinephrine and norepinephrine coming from the adrenal gland are for emergencies, right? So they're going to stimulate cardiac output and peripheral vasoconstriction. So if you are in a fight or flight response, we're going to have increased heart rate based on these neurohormones. Antidiuretic hormone was one we studied that is made in the hypothalamus and released by the posterior pituitary. Its job is to respond when we have low blood volume, right? So its job is to bring your blood pressure and blood volume up by causing you to keep, seek, or retain water. So it tells the kidneys not to get rid of water, to make your urine more concentrated. And it's sent out in response to low blood volume, high plasma osmotic concentration, or another hormone, angiotensin II. Angiotensin II is released in response to a decrease in blood pressure. It's also released by the kidneys, and it causes aldosterone to come out of the adrenal cortex. It causes antidiuretic hormone to be secreted from the posterior pituitary. It stimulates the thirst response. If you're thirsty, what are you going to do? You're going to go get water or a drink. And it stimulates cardiac output and peripheral vasoconstriction, trying to raise blood pressure. Erythropoietin is a hormone released by the kidneys in response to low blood pressure or low oxygen levels, because it's telling us we need more red blood cells to bind more oxygen. And so it will also cause red blood cell production and vasoconstriction. And here is another graphic that shows you what happens with decreasing blood pressure and volume and what happens with increased blood pressure and volume. The natriuretic peptides, the atrial one and the brain one, okay, they are going to be responding to having too much blood volume. So this is the opposite. You're having high blood pressure and too much blood volume. So the idea is get rid of fluid from the blood. That's what their goal is. So they're going to do the opposite of what antidiuretic hormone would do. They're going to cause the kidneys to get rid of more fluid, right? They're going to make sure that you're not absorbing more liquid in your digestive system, and you're going to be trying to flush out your body, basically getting rid of excess fluid. So your blood, your heart, and the rest of the cardiovascular system have to work together, and they have to respond to whatever your body's doing. If there's a physical or physiological change, for example, if you're exercising, we have to change the way it works. Or if we have blood loss occurring, we have to change the way it works in order to maintain homeostasis. Since oxygen is so vital to all of our tissues, we have to have our circulatory system working properly. So there are areas that get, prioritized. Some organs are so important that they have their own separate mechanisms to control their blood flow. And the three that are most important are your brain, your heart, and your lungs. Brain blood flow is a top priority. And if peripheral vessels in the body are constricting, cerebral vessels will dilate, making sure that the majority of the blood is getting pushed into the brain. A stroke or a cerebrovascular accident is the result of having either a blockage or a rupture of an artery in the brain, and it stops blood flow. Now, the big problem is, if you remember back from Anatomy 1, there is very little room inside the skull for any excess fluid. We very tightly control cerebral spinal fluid volume, and if we have blood now leaking into the skull, it begins to squash the brain tissue. And if you have a long-term cerebral hemorrhage, it actually forces the brain out through the foramen magnum of the skull and will shear it off at the brainstem level. That's a horrible, horrible thing to happen, but there's no way for your brain to release pressure. So if you have a cerebral hemorrhage, they will actually drill a hole in your skull to allow the blood pressure in your skull to drop, to get that excess fluid out. During a stroke, any area of brain that has been missing oxygen for any amount of time may begin to die and is non-recoverable. Now, when we get to the heart, we're of course feeding the heart with the coronary arteries. Now, the more active you are, the more your heart itself needs oxygen, right? Oxygen demand increases with more activity. Also, lactic acid and low oxygen levels cause coronary vessels to dilate. So if you're exercising and you can't keep up the oxygen intake, which is why you would switch to anaerobic respiration primarily and cause a buildup of lactic acid, we'll get into that a little bit into the metabolism chapter, then your heart knows it needs to increase its own blood flow to make sure it gets enough oxygen. Epinephrine, also known as adrenaline, also dilates coronary vessels, increases heart rate, and strengthens contraction so that we have more cardiac output. All right, so what's a heart attack? Well, just like a stroke is a blockage of a vessel to the brain, a heart attack or myocardial infarction is a blockage of blood flow to the heart. And it can cause chest pain, angina, tissue death and damage, heart failure, and death of the individual. Blood flow to the lungs is controlled by the alveoli. These are these little air sacs, and they are monitoring the O2 levels. If there's a lot of O2 in the alveoli, then vessels dilate so that they can get that oxygen into the bloodstream. If there is a low O2 content, vessels constrict. Now, dilating allows the blood to move more slowly so more oxygen can diffuse in. Constricting causes the blood in the vessels to move quickly so that it can grab the low oxygen and move on. So more blood can grab the oxygen. Okay, so what happens when you exercise? In the beginning, when you're exercising lightly, you have a lot of vasodilation and you increase circulation. Your venous return is increasing because you're squashing all those veins with moving skeletal muscles. And your cardiac output rises in response to the increase in venous return, or the Frank-Starling principle, and atrial stretching in the Bainbridge reflex. When you're in heavy exercise, you are activating the sympathetic nervous system, and you get to your maximum cardiac output level, which is about 4 times over resting level. And your body shifts and says, okay, if we are in serious exercise mode, then all the things like digesting food, absorbing nutrients, creating urine, and defecation are not important. And so it changes blood flow and reduces the blood flow to your digestive system to the minimal level to keep everybody alive with oxygen, and shifts the bulk of the oxygenated blood to your heart, your brain, your lungs, and your muscles. Of course, like I said, your brain blood flow is not affected. Okay, so here's what happens during rest, light exercise, and strenuous exercise. So it's just interesting to look at these numbers, and this is milliliters per minute. Regular moderate exercise moves low-density lipoproteins, also known as LDLs, out of the blood into the liver, and then the liver converts them to bile and excretes them. This will stop the formation of plaques that lead to atherosclerosis. It also reduces the risk of heart attack. It speeds recovery after a heart attack and reduces the symptoms of coronary artery disease. Now, I'm going to argue a little bit with the book. Actually, we have more problems with sugar causing inflammation of the lining of the vessels, being a leading cause of coronary artery disease and heart attack. So it's not necessarily the cholesterol. It's actually an inflammatory response to too much sugar. I will argue that. All right, so what happens when you start to hemorrhage or bleed? Well, your body's job is to maintain blood pressure and to restore blood volume. Short-term elevation of blood pressure. So we're going to increase cardiac output and cause peripheral vasoconstriction through the carotid and aortic reflexes. Then the sympathetic nervous system is going to constrict arterioles to try to raise the pressure. And then we're going to constrict the veins and venoconstriction. We're going to use hormones to increase cardiac output and increase peripheral vasoconstriction. Shock is what happens if you have lost 20% of total blood volume. Okay, so if you have a short-term response, it can compensate after blood losses of up to 20%. If they cannot restore blood volume and blood pressure, you go into shock. Long-term restoration means we need to put that volume of liquid back into the blood to raise the volume. So we take in all the extra interstitial space fluid. We will secrete aldosterone and antidiuretic hormone to bring in more fluids through thirst, through the digestive system, and through retaining of urine. And we will create new red blood cells to replace the ones lost in hemorrhaging by secreting erythropoietin. And here are more graphics that will talk about what happens after hemorrhaging. 3 general patterns emerge. Peripheral artery, this is talking about the distribution of blood vessels, okay? Peripheral artery and vein distribution is the same on the right and left, except near the heart. The same vessel may have different names in different locations as it moves through the body, and tissues and organs usually have multiple arteries and veins feeding them or draining blood from them, and they may be connected with anastomoses. Now, again, I'm going to remind you, the rest of the chapter is going through the vessels of the body, and it goes through every one. You do not have to know everyone for this task. You only have to know the ones that are listed in your orange lab manual. Now, it would be a good idea to know the order of blood flow through those vessels. There may be questions about blood flow through the leg, blood flow through the arm. So make sure you're very familiar with those vessels, but you don't have to worry about things like, the intercostal arteries. If it's not on your list, you don't have to know it. Okay? So it's showing you schematic overview of the pattern of circulation. Okay, this is the left side. This is the systemic circuit. So we take oxygenated blood and go through the aorta, and we go down to places like the kidneys, the digestive organs, the liver, the gonads, and the lower limbs from the descending aorta. And then we're going to have branches that go up and take it to the upper limbs and to the brain. Okay? And here is the venous return of the systemic circuit. Now, where are the differences between when you were a fetus and when you're an adult? We kind of mentioned these before. Embryonic lungs are non-functional, and so the baby gets all of its oxygen and nutrients from mom through diffusion through the placenta. So blood flows to the placenta through the umbilical cord. There are 2 umbilical arteries that come out of the iliac arteries of the fetus. So they're going away from the baby's heart. That's why they're called umbilical arteries, but they would be carrying deoxygenated blood. Blood comes back from the placenta through the singular umbilical vein on the way to the baby's heart, but it is the blood in the vein that has the oxygen, and it dumps into the inferior vena cava, which would then go right into the right atrium of the baby's heart. Before birth, the lungs are collapsed, and the baby gets all of its O2 by placental circulation. And the 2 changes that happen upon the birth is the foramen ovale actually seals up and becomes the fossa ovalis, and the ductus arteriosus, which was a shortcut between the pulmonary trunk and the aorta, becomes a hollow tube, basically disintegrates and becomes a ligament. It becomes ligamentum arteriosum. So here we go. There's the placenta. Here are the 2 umbilical arteries arising out of the internal iliacs. Okay, goes to the placenta, gets oxygen, comes back by the umbilical vein. The umbilical vein dumps into the inferior vena cava. Here is the foramen ovale, and here is the ductus arteriosus before birth. At birth, as soon as the newborn breathes air, the lungs expand, pulmonary vessels expand, and we snap shut the foramen ovale and the ductus arteriosus. And here's where it's happened. So the ductus arteriosus just becomes a ligament, and the foramen ovale becomes the fossa ovale. All right, guys, that is the end of chapter 21. I wish you happy studying and good luck on the exam.